Hello again, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me again is Dr. Andrea Baier from Monument Health, who is board certified in internal medicine, and you're also board certified with
Hospice and
Hospice,
care.
Thank you. That's right, which is what we're here to talk about today for sure. It's nice to have you back, Doctor. Of course, you. The last time we talked, you didn't tell me how long you've lived here, though, in the area.
8 years. 8
years. Okay, so you're still relatively new, I suppose. You like the Black Hills, you like the hiking, we talked in the last episode about your desire to get away from the ocean a little bit. I suppose, like with anything else, though, it just you just want to change, right?
Yeah, exactly. Yeah, we had our son was in 8th grade at the time, and we had spent so many years at the beach. We thought, well, now's a good time, getting ready to go into high school. What else do we want to see? And we thought, gosh, mountains would be nice. So,
well, it's great that you came out here. Did you, were there other places you were looking before you arrived? And kind of what drew you specifically to the area here?
I was looking in Boulder, Colorado, and Bozeman, Montana. Those are the places I was familiar with and had visited. And I didn't really know anything about Rapid City or South Dakota at all, honestly.
We hear that a lot.
But a headhunter had noticed my search online and called and said, what about Rapid City, South Dakota? And he said, look it up, and I'll call you back tomorrow. And I looked it up, and it looked really cool.
It fit. Well, you've been here 8 years. That's great. That's awesome. All right. Well, today we wanted to, like we said, talk about hospice care. And you, when we were kind of getting this all set up, you had emailed and asked if we could also throw in what's called palliative care, correct?
Correct.
I had never heard that term before. I think most of us are familiar with what hospice care is, but let's talk about what those two things are specifically. Start with hospice.
Hospice is really technically a Medicare designation, but it means that if your disease follows the expected course, that we would expect that the person would pass within 6 months. It also means that they're not going to try to do things to prolong their life. For instance, a cancer patient would not get chemotherapy anymore. However, if they felt that radiation would make their symptoms better, they could still get radiation. They would just stop doing things with the intention of prolonging life and turn their attention more toward things that will make their quality of life better.
Okay. Then what's palliative care?
Palliative care is a type of medicine, a specialty for anybody who has a serious or life-limiting illness. So it can be anybody. It can be Parkinson's, ALS, COPD, like emphysema, congestive heart failure. And we get many patients with different types of illnesses, but they're serious and they have, effects on their quality of life. So we try, as they're walking through treatment, getting the chemotherapy or that sort of thing, try to help them with symptoms that they have either from the treatment or from the disease, so that as they're going through this, they have the best quality of life that they can.
Okay, so it's well, then how is that really different from what just general practice doctors would do for somebody that has these conditions? Does that make sense? Am I asking that? Okay.
Yeah. And it really varies a lot by primary care physician in terms of their comfort level. When you look at cancer patients, sometimes their pain can be very complex and hard to treat. And so there's medications that we use that we're more comfortable with than, an average primary care doctor is not as familiar with them, and they can be concerning. Also, a lot of physicians are worried about prescribing controlled substances. The DEA keeps a close eye on what we prescribe, and so it's easier in my specialty to be able to prescribe and not worry about that so much as versus if I, was an internist or a family practice doc. I might worry a little bit more about being scrutinized.
I see. Well, that's really interesting, though, but to differentiate that way. What is kind of the philosophy behind hospice care? How did it kind of come about, or why is it necessary?
The philosophy behind hospice care is just to help people live as well as they can. So they have a limited amount of time, and they know that they do. And they're tired of running to the doctor. They're tired of coming back in the hospital, and they just want to use that time to the best of their advantage. So, folks can travel, they can visit and spend time with family, and they're not constantly running, to get medical procedures and that sort of thing. So our goal is to help make that time that they have really good and help them, if they have goals, things that they would like to achieve, we try to help them do those things.
Has it been around a long time, or is hospice a recent thing?
It's been around since I think the early 70s. It started in
so it's relatively
England.
new. Okay.
Yeah. And then it's sort of grown over the years as patients and doctors have become more educated about it and more comfortable in terms of talking about end-of-life issues.
Yeah. Okay. Do you have a team that works with you?
We do.
Okay.
Yeah. Everybody on hospice, it's almost like a menu. They can pick and choose which team members they want. You have to have a doctor who is one main point of contact. So it can be your primary care doctor, or it can be one of the doctors employed by hospice like me. Everybody has to have a nurse. So those are the two things you have to have. And then there's aides that can come in and assist with bathing. Social workers, are very helpful in terms of helping people talk through hard issues, but also with practical things like how do I apply for Medicaid, or how do I do funeral planning, or that sort of thing. Chaplains are available, and then volunteers can come in and do things like meal preparation, yard work, just stay with somebody so their caregiver can go to an appointment or just get out for a little bit. So
I suppose volunteering, that's kind of an important aspect of this too, isn't it?
Very important.
Is it?
Yeah. Our volunteers are wonderful, and they make a big difference because some of these folks are honestly kind of lonely. And so sometimes just that visit, to have somebody that they're familiar with to sit and talk to, is really nice.
How do you qualify for hospice care?
They're pretty specific.
Is it?
Criteria. So for every diagnosis that somebody has, say congestive heart failure or liver disease, Medicare has spelled out specifically what they expect to see, certain lab values, certain issues that have come up over time. Typically with a cancer patient, like I said, it's when they're okay with not having more chemotherapy, or they just don't qualify for any more. They've exhausted all the options, and more therapy would just do more harm than good. So once you have a qualifying diagnosis and it meets that Medicare criteria, then the second piece of that is you have to be of that philosophy. You have to be okay with saying, look, I'm not going to try to prolong this. I just want to make it as good as I can and not return to the hospital.
I see. I guess in just talking with you here, that's something I didn't consider, is that there are moments, I suppose, when you're fighting these certain conditions that you do just get tired of it. At some point, you know that you've done everything you can, and the last thing you want to do is go to another waiting room and talk to another doctor, right?
Yep.
So that philosophy you talk about is very interesting, because you have to be. I can't imagine that decision. That's got to be very hard for some people.
It can be very difficult, especially when you've spent so much time, like you said, fighting. That's such our mindset is, I'm going to fight this, I'm going to beat this, and then to reach a point where you understand that you're not going to beat it anymore. Right. And that can be a hard transition, especially almost more for families than for the patient themselves.
Are there different levels of hospice care that's available? I mean, we've kind of talked about the two main, but do they break down at all?
They do.
Okay.
Yeah. Hospice, we always say, is a philosophy, not a place. I think sometimes people think when they go onto hospice, that means they go into hospice, which means they go somewhere. But most of our patients are at home.
That's a great point, because, in my mind, I always thought, it's a place you have to be. But
yep. Nope. You can have hospice care anywhere. So in your home, in a family member's home. We've had patients in hotels, nursing homes, and then we do have the hospice house here in Rapid City, which is a beautiful building. So people, if you qualify for hospice, you can be in the hospice house. Some people just choose to be there because they don't really have help at home. Some people go if their symptoms are difficult to manage at home. It's just more than they and their family are comfortable doing. So we can bring them in, get those symptoms under control with the goal of getting them back home. And that is covered by Medicare when they come in. And the third, it would be respite. So if your family members just need a break, they have to have surgery or they want to take a vacation or they just are tired, people can come in and stay for up to 5 days and Medicare covers that and then they return back home.
Okay. Are there any myths about hospice that you wish didn't exist?
Yes.
I just saw your eyes light up with that question right there.
Yeah. There are lots of
Are
myths
there?
about hospice.
What are some that you just wish you could put to bed right now?
I would say the biggest myth that really keeps people from going on to hospice or even considering it is that they think we stop everything. So, for instance, somebody with lung disease or heart disease, they're worried we're going to take away their oxygen or their nebulizers, and that's absolutely not what happens. So, any medicine or treatment that you're on that will help you feel better, we continue. So, your heart medicine, your lung medicine, your nebulizers, of course, your oxygen, all of those things continue. We take, I don't want to say take away, but hospice doesn't typically cover things that I call fluffy medicines like cholesterol pills and vitamins. Right. Those don't really make you feel better in the moment. But most of the medications and treatments that people are on will continue even when they enroll in hospice.
Okay. That seemed to be the biggest myth you would love to dispel right there.
Yes.
That is good to know. Because that'd be scary. You think, oh, now I'm going into here where, chances are this is going to be my last stop and I don't get anything to help.
Exactly.
Right.
Yeah. And that's scary. It's concerning to think that your symptoms are going to be uncontrolled and you're not going to have your usual medicine to treat it. And that's just not the case. And I think when people realize that, it makes them feel a lot better.
What are the first steps? How do you get started then with this process? If somebody right now is hearing this and thinking about it, where do they turn first?
Their primary care provider would be a good place to start. Now, for cancer patients or patients, say, with ALS who see a neurologist, sometimes it's that specialist who is more in the forefront of treating them. They can also call our palliative care line, and I see many patients that we talk through kind of what their goals of care are, and are they ready for hospice? Are they medically ready? And also, are they kind of emotionally ready for it? And that's something that we can spend a lot of time talking about. But the simplest place to start would be your primary care doc.
Okay, excellent. Kind of a personal question, how do you manage this? Because you see the end in a lot of instances, correct?
Yes.
Is it? Do you go home some nights pretty tired?
Yes. Definitely. But I really try to focus on it being just a different way of helping people. When you can't help them in the traditional way anymore, this is the way that you can help them. And so often, I think when people have a serious illness, people don't know how to react to it. They don't know how to talk about it. And so they don't, and they can feel sort of alone. And so we talk about it openly, and it helps them feel supported. We meet them where they are.
Okay. Well, it's been a lot of fun to talk to you, Doctor. Was this the field you wanted to go into when you started this in medicine?
No. Actually, I had intended to go into critical care.
Okay.
And due to some family reasons, I had to cancel that, and then was a hospitalist for a number of years. And one of my partners started a palliative care program at my hospital in Maryland and asked if I would help. And I did, and then kind of got grandfathered in, sat for the boards, and the next thing I know, people are contacting me for jobs. And the more I did it, the more I grew to really like it. And so I'm happy to be doing it now full time.
Ah, that's excellent. It's been so nice to talk to you, Dr. Dr. Andrea Baier, who is board certified in hospice and palliative care and internal medicine as well from Monument Health. Thank you for coming in and talking. And anytime you want to have another conversation like this, I'm glad to do it, Doctor.
Great. Thanks for having me.